Hey everyone, welcome to MediByte. I am absolutely thrilled you're tuning in today. We are unpacking a rare but frankly critical childbirth emergency. Now, as a healthcare professional, I know delivery room complications can seem super intimidating, but don't worry. Our goal with this explainer is to map out the exact clinical mechanics behind these events safely, clearly, and simply. We're going to be looking at a condition called uterine inversion and its closely related partner in crime, placenta accreta. All right, let's dive right in.
So what actually happens when the uterus turns inside out? Honestly, it sounds like a dramatic cliffhanger from a medical TV show, right? But while it definitely sounds frightening, it's a very real, though thankfully rare, childbirth emergency. And the good news? Delivery teams are highly trained to handle it. Today, we're going to break down exactly why this happens, who's most at risk, and the precise, on-the-spot steps medical professionals take to save lives.
Here's our roadmap for today's explainer. We'll kick things off with the uterine inversion emergency itself. Then, we'll unpack the stubborn placenta connection. After that, we'll cover identifying high-risk pregnancies, how we diagnose before delivery, and finally, those swift, life-saving treatments.
Okay, part 1, the uterine inversion emergency. Let's step right into the delivery room, where literally every single second counts.
Uterine inversion is exactly what it sounds like. It's a rare emergency where the uterus actually turns inside out. It protrudes right down through the cervix, and sometimes it can even extend completely out through the vagina. What's absolutely crucial to understand here is the dynamic shift in anatomy. This isn't just some minor complication. It causes severe sudden blood loss that can be immediately life-threatening. The medical team has to recognize it instantly.
Section 2, the stubborn placenta connection. Let's put on our medical detective hats for a second and figure out why this inversion actually happens.
Well, the primary culprit is often a condition called placenta accreta. Basically, this is a placenta with an abnormally firm attachment to the uterine wall. It's like it's glued on there. So the crucial point is this. If the placenta is attached far too firmly and doctors pull hard to remove it after the baby is born, that intense physical traction can actually pull the uterus down along with the placenta. It literally turns the whole organ inside out.
Mechanically speaking, the difference is night and day. In a normal delivery, the placenta naturally detaches. It's gently pushed out by the mother or assisted by the doctor or midwife. Smooth and simple. But with placenta accreta, parts of it remain stubbornly attached. And because the delivery of the placenta is delayed, the risks of bleeding and infection in the uterus absolutely skyrocket. Clinical data stresses that this bleeding can become life-threatening incredibly fast.
Moving on to Section 3, identifying high-risk pregnancies. Knowing these severe dangers, how do medical teams actually get ahead of this?
Well, doctors proactively look for clues. The biggest risk factors for placenta accreta include having had a previous cesarean delivery or having placenta previa, which is when the placenta covers the cervix. And here's the thing, if a mother has both of these factors, the risk jumps significantly. Other red flags include being 35 or older, having multiple prior pregnancies, uterine fibroids, or having had prior surgery to remove those fibroids. Even disorders that scar the uterine lining, like Asherman syndrome, play a major role. And it's incredibly important to note that as cesarean rates have gone up here in the US, the rates of placenta accreta have climbed right along with them. It's a real trend.
Okay, Section 4, diagnosing before delivery. Once a care team spots a high-risk patient, what's the very next step? It's all about a proactive diagnostic timeline. Around 20 to 24 weeks of pregnancy, doctors do periodic ultrasound screenings. They'll use a device either on the abdomen or inside the vagina to check for that abnormal placental attachment. And if the ultrasound isn't totally clear, they might order an MRI to get a better look. But, sometimes it just isn't diagnosed until the actual delivery. Warning signs in the delivery room include 30 minutes passing without the placenta delivering, doctors being physically unable to separate it by hand, or, worst case scenario, attempting to remove it and immediately triggering profuse bleeding. Finally, Section 5, swift and life-saving treatments. If an inversion or accreta emergency strikes, what actually happens next?
I really want to reassure you here, modern medicine has highly specific, super fast-acting protocols for this. For a uterine inversion, it is a rapid response, right-on-the-spot situation. Step 1, doctors promptly work to manually return the uterus to its normal position by literally pushing it back up. Step 2, they might give intravenous turbuline. This safely relaxes the uterus, making it much easier to push back into place. In Step 3, to combat the blood loss, they immediately provide IV fluids or a blood transfusion. Patients get pain relievers, sedatives, sometimes even a general anesthetic for the procedure.
And the fantastic news, most women recover completely after this prompt manual treatment. Surgery is only occasionally needed to fix the inversion.
But what if doctors diagnose placenta accreta firmly before delivery? They definitely don't want to risk an inversion or massive hemorrhage on the big day, so instead they typically plan a cesarean hysterectomy a few weeks before the due date, usually around 34 weeks. During this procedure, the baby is delivered by cesarean first. Then, to safely bypass the risk of that life-threatening blood loss, they remove the entire uterus with the stubbornly attached placenta still safely inside it. Now, because this is a major operation requiring a deeply experienced team, post-surgical risks are a reality we have to face. As the clinical data notes, blood clots can travel through the bloodstream and block an artery in the lungs, which is a condition called a pulmonary embolism. This can happen if the surgery takes a long time or if it requires a long period of bed rest afterward. It perfectly illustrates exactly why proactive, specialized care is so vital.
Understandably, a hysterectomy means the end of childbearing, and that's a heavy reality. On a compassionate note, if having more children is important to a patient, doctors absolutely try to preserve the uterus using various specialized techniques. However, we have to be clear. These preservation techniques simply cannot be used if the bleeding is extremely heavy, or is likely to be extremely heavy based on the placenta's location. Ultimately, maternal survival and managing extreme hemorrhage just have to come first.
We've covered some incredibly dramatic and fascinating clinical ground today, so I want to leave you with this thought. As medical protocols continue to evolve to safely handle these intense childbirth complications, what is the future of maternal care going to look like? Honestly, it's just awe-inspiring how skilled medical teams navigate these critical emergencies. Thank you so much for joining me on this MediByte Explainer. I really hope this empowers you with clearer, factual medical knowledge. If you found this breakdown helpful, please be sure to hit that like button, share this explainer with your network, and subscribe to the MediByte channel for more deep dives into the fascinating world of healthcare. Stay curious, and we'll see you next time.